Surgical management of tubotympanic disease. If, as a consequence of adequate medical management, tubotympanic disease persists, what are the therapeutic options? Or once the ear becomes dry, what do we do? The aim of surgery is to provide a safe, dry, and a hearing ear. Adenoidectomy, septoplasty, and antral washes may be required in some cases where the predisposing factors are in the nose and paranasal sinuses. Oral polypectomy. Oral polypectomy should be done under general anesthesia using a microscope. Why? Because the oral polyp should be removed with utmost care, as it may be attached to the oval or round window or even the facial nerve. Myrioplasty. When the ear has become dry, the tympanic membrane defect should be sealed off as to prevent further infection of the middle ear as well as to improve hearing. Let us have a look at myrioplasty. What are the prerequisites? Number 1, the ear should be dry for at least 6 weeks before myrioplasty is done. 2, the eustachian tube should be patent. 3, there should be no focus of infection in the nose, paranasal sinuses, and nasopharynx. And 4, there should be adequate cochlear reserve. What are the advantages of myrioplasty? Number 1, to prevent further infection of the ear. 2, to improve the hearing or to prevent further deterioration. 3, to prevent complications. 4, the drying effect of air has been implicated as an etiologic factor for tympanic sclerosis and therefore to prevent tympanic sclerosis. 5, to enable proper fitting of a hearing aid. 6, to enable recruitment in certain professions. These constitute the advantages of myrioplasty. Graft material. The temporalis fascia is the most commonly used material for myrioplasty. To obtain this, an incision is made in the post-oral groove just behind the pinna. The incision goes right through the skin superficial fascia, exposing the underlying temporalis fascia. It becomes easy to dissect the fascia if normal saline is injected under it, thereby separating it from the muscle. The fascia is then allowed to dry before use. Temporalis fascia has also been successfully used as a homograft by preserving a large piece of fascia in 70% alcohol or in 0.02% aqueous synlint preservative and using it a number of times. Tracheal pericontium and homograft tympanic membrane are also used by some. Procedure. Underlay technique. The bed for the graft is prepared by elevating the canal skin adjacent to the annulus and the outer squamous epithelium layer of the drum remnant. The graft is applied and kept in position by gel foam soaked in antibiotic solution. Underlay technique. This is suitable for a large posterior perforation, especially when the anterior remnant is thin and atrophic. The rim of the perforation is removed and adjacent mucosa is sacrificed. The tympanic membrane remnant, along with the annulus, is lifted anteriorly. The middle ear is packed with gel foam soaked in antibiotic solution. Then the graft is placed under the tympanic membrane remnant. Posteriorly, it lies over the canal wall. There is another technique called interlay. Why? Because when it is placed underlay, the mucosa of the middle ear can grow through the perforation over it and then cause mucositis. Consequently, an extended tympanomeatal flap, including the outer canal wall epithelium, is in a circular fashion cut and elevated, and the graft is positioned on the bare bone and the flap is repositioned back, thereby not allowing the mucosa to grow through the perforation. This is called the Underlay Technique. Post-operative care. Antibiotics and nasal decongestants are prescribed. If the Underlay technique has been used, the patient is instructed to do the Valsalva maneuver from the second day to facilitate contact between the graft and the bed. The gauze pack is removed on the 10th day and the gel form is removed after 3 weeks. If, in spite of adequate medical management, the ear continues to discharge, then we look at the possibility of cortical mastodectomy. Cortical mastodectomy, also known as simple or complete mastodectomy or Schwartz operation, is complete exenteration of all accessible mastoid hair cells and converting them into a single cavity. The posterior meatal wall is left intact, and thereby this is known as the canal wall up surgery. Medullary structures are not disturbed. Indications: acute coalescent mastoiditis, incompletely resolved acute otitis media with reservoir sign, masked mastoiditis, and as an initial step to perform endolymphatic sac surgery, decompression of facial nerve, translabyrinthine or retrolabyrinthine procedures for acoustic neuroma. Anesthesia, generally done under general anesthesia. Position: the patient lies with the face turned to one side and the ear to be operated uppermost. Steps: a curved postoral incision called the postoral incision of Wild about 1 centimeter behind but parallel to the retroauricular sulcus, starting at the highest attachment of the pinna to the mastoid tip. In infants and children up to 2 years, the incision is short and more horizontal. Now, this is to avoid cutting the facial nerve, which is more superficial in the lower part of the mastoid. The incision cuts through the soft tissues up to the periosteum. Temporalis muscle is not cut in the incision. This is the postoral incision of Wild, a few millimeters behind the postoral sulcus. Exposure: the exposure of the lateral surface of the mastoid and the Messivan's triangle is done. Periosteum is incised in the line of the first incision. A horizontal incision may be made along the lower border of the temporalis muscle for greater exposure. The periosteum is scraped from the surface of mastoid and posterior-superior margin of the osseous meatus. Tendinous fibers of sternomastoid are sharply cut and scraped down. A self-retaining mastoid retractor is applied. Removal of the mastoid cortex and exposure of antrum. The mastoid cortex is removed with burr, gouge, and hammer. Either a burr or a gouge and a hammer. The mastoid antrum is exposed in the area of the suprameatal triangle. In an adult, the antrum lies 12 to 15 mm from the surface. The horizontal semicircular canal is identified, keeping in mind the presence of cornus septum, which would need removal to explore the antrum. Removal of mastoid hair cells. All accessible mastoid hair cells are removed, leaving behind the bony plate of the tegment tympani above, the sinus plate behind, and the posterior meatal wall in front. Removal of the mastoid tip and finishing the cavity. Lateral wall of the mastoid tip is removed, exposing muscle fibers of the posterior belly of digastric. The zygomatic cells situated in the root of the zygoma, the retrosinus cells lying between the sinus plate and cortex, behind the sinus, are removed. A finished cavity should have beveled edges so that soft tissue can easily sit in and obliterate the cavity. Let us have a look at the limits of cortical mastodectomy. Above is the dural plate, behind is the sinus plate, below is the digastric ridge, and in front is the posterior superior bony meatal wall, and therefore called a canal wall up surgery. These constitute the limits of cortical mastoidectomy. Closure of wound. Mastoid cavity is thoroughly irrigated and with saline to remove bone dust, and the wound is closed in layers. 2 layers. A rubber drain may be left at the lower end of the incision for 24 to 48 hours in case of infection or excessive bleeding. A meatal pack should be kept to avoid stenosis of ear canal. Mastoid dressing is thereafter applied. Post-operative care. Antibiotics started preoperatively are continued post-op for at least a week. Culture swab taken from the mastoid during surgery may dictate a change in the antibiotic. Drain, if put, is removed in 24 to 48 hours and sterile dressing is done. On the 6th day, the stitches are removed. Complications. Injury to facial nerve, dislocation of the incus, injury to the horizontal semicircular canal, since the patient will have post-operative giddiness and nystagmus if injured, injury to the sigmoid sinus with profuse bleeding, injury to the dura of middle cranial fossa, post-op wound infection and wound breakdown. We have had a comprehensive look at the surgical management of tubotympanic disease.